Good morning. My name is Charlene Obernauer. It's nice to see you all. I'm the Executive Director of NYCOSH. And if you are logged in this morning, you are here for our Long COVID and Workers' Compensation Forum. We're going to have conversations with our expert panelists on long COVID as an occupational health crisis. We're going to talk about the underutilization of workers' compensation as it results to long COVID and what the benefits and protections are. If you're interested for yourself or for your members, you're going to get briefed on that. And if you've never seen me and don't know who I am or who NYCOSH is the New York Committee for Occupational Safety and Health. We are hosting this forum today. And we are an organization that focuses on education and advocacy. We train between 15 to 20,000 workers every year. You may have seen some of our work through the Nail Salon Worker School or the Construction Safety School. Although we are not industry specific, those are two industries that we do a lot of training around. We also conduct training for the World Trade Center Health Program. This is for responders and survivors of 9/11. Some of you may be currently enrolled. And yes, this is still an ongoing program nearly 20 years later. Finally, advocacy is one of our focuses as an organization. You may have seen that most recently we launched statewide legislation for a temperature standard to protect workers, which is going to be one of our big campaigns this year. And that's it about NYCOSH. I want to kind of get us started here with our panelists, because I know we all have a lot to say and you have a lot that you're probably interested in hearing about. Our first panelist is Dr. Michael Crane. He, as the World Trade Center Health Program Clinical Center of Excellence for Mount Sinai, Dr. Crane leads the team of health providers in the provision of monitoring and treatment of services for over 21,000 World Trade Center health responders. Since 2006, Dr. Crane and his colleagues have worked to expand the size and scope of the Mount Sinai World Trade Center Health Program. As medical director of the Mount Sinai Silikoff Centers for Occupational Health, Dr. Crane plans, directs, and evaluates services by the Mount Sinai's World Trade Center Health Program, Clinical Center of Excellence, 2 of New York State Department of Health funded occupational health clinic networks, and several similar programs. I'm going to now turn the floor over to Dr. Crane. Thank you.
Thanks so much. And now the unmasking. Don't run. Thanks, and thanks, Charlene. I'm just going to talk a little bit about long COVID. But first, let me just answer the question you probably have about what am I doing here? I'm an occupational medicine doctor. I talk about work-related health, work-related problems. I'm no infectious disease specialist, so what am I doing here? Well, I think it's obvious to all of us that COVID has absolutely invaded every aspect of our life, our home, our schools, and certainly our workplaces. And workers have gotten sick from exposure to COVID at work. There's no question about it. And as a consequence of that exposure, home or school or family, whatever, they not only got this acute illness known as COVID, where they could get very sick for a relatively short period of time, maybe a couple of weeks, sick enough to be hospitalized, however, and sick enough to be in the ICU, sick enough to die. No question about that. But they were also exposed at work and became sick at work. And therefore, as Robert will say later, they are entitled to compensation, workers' compensation, for that type of illness. But that's part and parcel of our discussion. Let's just move on and talk a little bit about the syndrome. Again, I disqualify myself immediately because I am not an infectious disease specialist, but rather I'll call myself an interested amateur for the purposes of this discussion. So a little clinical background. The COVID is one of a group that medical scientists talk about, post-acute infectious syndromes. Very fancy sounding nerve, but what it means is that when you get a virus, which typically lasts in most people, maybe days, a couple of weeks. For some folks, it goes on longer. The impact goes on longer. And that has been known for a century, way back to the flu epidemic, back at the beginning of the last century, and forward and after that. It's caused by a variety of infectious organisms. They have symptoms such as intolerance for exercise, fatigue, These fancy words, neurocognitive, the sensory impairment, much better word for that is the brain fog, I think, and people are familiar with that. Poor sleep, muscle and joint pain, a tremendous amount of anxiety because people don't know what the heck is wrong with them. I got sick, but why aren't I better? So tremendous anxiety. And not a lot of help from us for a while because we really didn't recognize that this syndrome was connected to this virus. We learned quickly, but not quickly enough for some of our patients who felt sort of abandoned. Well, the jury is out. This really happens due to COVID. If you have this syndrome, you are not lazy, you are not crazy, you are not a bad person, you're ill with a syndrome caused by the virus, okay? And there's been a lot of shame and guilt about people who suffered with this. What's the matter with me? Am I crazy? No, you have a syndrome caused by the virus. So let's get rid of the shame and the shaming about long COVID. So let's talk a little bit more about what we find. If you look back in the medical literature, you can see that many of these organisms that are on the chart cause this type of syndrome. And there are many more than that. There are many, many more than that. The symptoms are similar in many cases: exercise intolerance, fatigue and exhaustion, the neurocognitive and sensory impairment, again, that brain fog, poor sleep, muscle and joint pain, and many, many other symptoms that are really too many to categorize in a few minutes. And these go undiagnosed. Certainly, they went undiagnosed at the beginning of the COVID because the doctors sort of didn't realize they were connected, even though they were very interested in asking all the questions. The symptoms are very nonspecific. If you have muscle aches, there's 1,000 reasons to have muscle aches. But for many of our patients who had COVID, the muscle symptoms were directly related to the virus. So here's some of the other bugs that cause this syndrome. And you can see there's a lot of them. Polio, SARS, Epstein-Barr, lots of other viruses. The flu. The flu causes a syndrome like that and has been known to do that. So, you know, we have to understand that this syndrome, post-acute COVID, is part and parcel of that virus. So let's take a look and see about what people have been saying about who tried to study this. So early on, in fact, let's just step back a second. When we first talked about having this discussion, it was Halloween or so, right back around October, and then things got delayed. I mean, when we went to look at the literature, there's very little actual literature about long COVID and what was happening. There was a lot of interest, research was ongoing, but the publications really hadn't come through yet. So when we were starting to look for articles, well, there were relatively few. Now, I am happy to say, I think that there's one or another article coming back almost weekly or daily, and a tremendous explosion of medical interest in this syndrome. So folks who have this, folks who had this, take heart, help is on the way. Really, really skillful people are looking at this and are going to find answers. But the long COVID study was one of the earliest. They got together in Scotland, a group of over 100,000 members of the general population, and they followed them up after they were testing. So what did they find? So 96,000 people, 33,000, excuse me, had positive tests. Most of them had symptoms. Okay, so a very highly symptomatic population. And 63,000 patients with negative tests. That's the kind of control group. Okay, so they're 45 years old. It's Scotland, and mostly white people, mostly male in this, mostly female. I'm sorry, in this group. And I put in red here 4% vaccinated. That will turn out to be kind of an important point because subsequently it's been shown that the vaccination seems to reduce the frequency with which the long COVID occurs, cuts it by more than half. So a 4% vaccination rate, very low, would say that there would likely be a lot of long COVID in this population, knowing what we know now. So then they looked at them at 6, 12, 18 months. So 33,000 with a positive test, 31,000 of them symptoms, 4% had one symptom, 6 for 2, 8 had 3, 80% had more than 3 symptoms. 80%. That is a very a large number of symptoms to walk out of a viral illness with. And again, these were mostly non-specific. Nothing a doctor could put his or her hands on and say, aha, you have a muscle ache, it's long COVID. And here's the listing. They looked at the symptoms in the infected population as opposed to the control population. And as you can see, tiredness, pretty common in both populations. Headache, the same in both populations. Their point of this is the symptoms are very different, but there's not a lot distinguishing long COVID from aches and pains and difficulties in the general population. Change in taste and smell, yes, that turned out to be kind of a signal, but and confusion and difficulty concentrating, that brain fog, good bit more common. But again, the symptoms that are seen in most long COVID patients tend to be quite common and seen in lots of people with lots of different types of illnesses. So what happened when they started counting up the days? Well, 6% of the people reported no recovery at all at up to up to 18 months after seeing at 6 and 12 and 18 months. And 40% reported only partial recovery. So almost half the people didn't get better from 12 to 18 months. Long COVID. Again, keep in mind, this is a very low vaccination population. So let's just go on. But it has implications for us today and for New York State. So if you have 7 million COVID cases among New York State residents, which is what we have now, in fact, more than that, the Scottish findings indicate that as many as 3 million of them had these symptoms. 3 million. Now, we talk about occupational health. 3 million people, that's certainly going to mean workers are affected. It's just a mass population infection, and it affects all areas of life, including the workplace. So another very interesting study was done more recently and in the United States. These folks took a random sample of the adult population. This study was done by folks down at City University, and we're very proud of our fellow New Yorkers for doing this. And they identified long COVID in 7% of the participants. Now, the way they structured this population, it was sort of like a polling company would do at the time of an election. They tried to get a stratified population that represented similar representation of people as in the general population of the United States. So it's sort of a snapshot of the US. So the finding that 7% of people are carrying the long COVID around with them at this point says that there's millions and millions of US adults contemporaneously walking around with long COVID. Most of them, of the folks reported the symptom duration of greater than 6 months. 25% indicated a lot of impact on their daily activities. And they did say, however, that seemed to be declining over a period of 12 to 18 months, but it's 12 to 18 months. Long COVID is long, even in the United States, even very recently. There was a higher prevalence among females. That's been seen in many studies, that females have almost twice the rate of males. The explanation is not at all clear at this point. It's more common in adults with comorbidities, diabetes, hypertension, and adults who are unvaccinated or not boosted. So if you looked at these results, right, and then said, okay, where are we in New York State? There's 1 million adults walking around New York State now with long COVID right now. So let's go back to the workforce. Does 1 million adults being sick affect the workplace? Oh yeah, right? You can't go into the workplace if you got brain fog. You know, you're gonna mess up and your boss will say to you, what the heck's going on? These symptoms impair people for a long period of time. This has to be taken seriously. You're not faking it. You're not making it up. You're not crazy. You have a post-viral syndrome. Okay, let's just move it forward. So what about vaccination? Well, I think, accumulating evidence now that the vaccination seems to reduce the frequency of long COVID. The latest numbers that I've seen, it basically cuts the rate in half or less. And I don't have any information about the bivalent or the monovalent, whatever. But vaccination does seem to lower the incidence, and also for people who have the COVID, some studies show that getting vaccinated improves their symptoms fairly rapidly. Again, that's not solid yet. It's only been reported a bit. So just to summarize, long COVID is a post-acute infectious syndrome, has impacted millions of Americans. These syndromes are well known and described in other viruses. The post-acute syndromes are fairly common and well documented in the medical literature, but we doctors have a hard time seeing them, particularly in the midst of a new pandemic, trying to separate out what's post and what's just new symptoms. And now multiple studies that have documented long COVID and treatment approaches are slowly developing. And I think that's where I end up. And where do we go from here? Dave's going to be on deck. And okay, thanks so much.
Thank you so much, Dr. Crane. And I want to say hi to the 117 people who are joining us right now on Zoom. That's a lot of you, so I'm glad there's such high interest in the topic. And we're going to continue on with our panel. Dr. David Petrino is a physical therapist with a PhD in neuroscience. He is currently the Director of Rehabilitation Innovation for the Mount Sinai Health System and an Associate Professor of Rehabilitation and Human Performance at the Icahn School of Medicine at Mount Sinai. He develops innovative rehabilitation solutions for adults and children in need of better healthcare accessibility, and in 2019, he was named Global Australian of the Year for his contributions to healthcare. Since the beginning of the COVID-19 pandemic in 2020, David has been recognized globally as a leading expert in the assessment, treatment, and underlying physiology of long COVID. His team has managed the care of over 2,000 people with long COVID and published multiple peer-reviewed scientific papers on the topic. Dr. Petrino.
Okay, well, thank you so much for the intro, and thank you for having me here to talk about this. This is such an important topic that we need to cover. I'm going to sort of pick up where Dr. Crane left off and try and add a little bit of additional nuance to what it means to be diagnosed with long COVID. The first thing I want to start off with is just the clinical case definition that the World Health Organization put out about long COVID. And I want to highlight a few things about this clinical case definition. So there's a lot of words on the screen, but basically it can be boiled down into a really simple concept. If someone has been infected with the SARS-CoV-2 virus, and after 3 months from their infection date, they still really are not feeling well, they're not feeling the same as they did before their infection, that means they have long COVID. So that's really as simple as we can make the initial definition. There's a few things that I want to really highlight. The first is that World Health Organization and the CDC stress that you do not need a confirmed SARS-CoV-2 infection to diagnose long COVID, because both organizations understood that historically and currently excluded groups in healthcare would have a disproportionately hard time getting that positive PCR test, getting that antibody test. They also understand, because they're scientists, that around 20 to 30% of the general population don't seroconvert after an acute SARS-CoV-2 infection, meaning antibody tests are wrong all the time. These are not good biomarkers for who has had COVID and who hasn't. So both of these organizations, CDC and World Health Organization, stressed the idea that you use your clinical judgment to diagnose long COVID. You don't need a test to diagnose long COVID. So this is one of the first things I think we need to keep drumming into people as insurance claims and workers' comp claims and long-term and short-term disability claims get denied because there's no test. All of the clinical guidelines that we have for this illness don't require a test. They're very explicit about that. So I think that we need to really internalize that and understand that that is a point of order that has been put forth by some of our most prestigious scientific organizations and medical organizations in the world. The next thing to acknowledge about long COVID is that we just have a lot of symptoms. So this was one of the more comprehensive symptom profiling papers that was published by a patient-led organization showing over 200 presenting symptoms, 10 organ systems being affected. So the idea is, the idea to take away from this is that long COVID can look lots of different ways. There is no single presentation that people come in with. But we just need to acknowledge that the virus is doing a lot of different things to a lot of different organ systems. And which obviously begs the question, how to diagnose long COVID if it's so variable and it's so, imprecise in terms of what it looks like. This seems like a hard question, but it's actually a really easy question. The first thing to understand is that we're not talking about a diagnosis of exclusion. We're not trying to say, well, we've tested you for everything else, so you must have long COVID. We're asking clinicians to be very clinically minded and understand the clinical history of a patient and understand what their past medical history is, what their current medical history is, consider how this onset of new symptoms lines up with an acute COVID infection, and make the diagnosis from there. So we're not saying you throw your hands up in the air and when you don't know what to diagnose, you diagnose long COVID. Not at all. You just need to complete a good subjective history, clinical history with your patients to understand, what you're diagnosing. So, I know this is a radical idea, but listen to your patients. That is how you diagnose long COVID. Hear what they're saying, understand the timeline and the onset of symptoms, and move it along. So that's diagnosis. So now the other piece I wanted to really dig into was how a long COVID diagnosis is a spectrum. We stood up a diagnosis of long COVID. We stood up clinical case definitions of long COVID, post-COVID condition, post-acute sequelae of COVID. These are all interchangeable terms. They all mean the same thing, which is people who are just not feeling right after their acute COVID infection. And we stood them up with this idea that they would really be an umbrella term to describe a whole number of different conditions, not necessarily one condition. And so what I like to do is split long COVID diagnoses into two groups with the acknowledgement, this is a Venn diagram, the acknowledgement that sometimes the groups overlap because nothing is simple ever. But the idea is that if we think about illnesses that occur as a result of a COVID infection, where we can very clearly link the illness to organ function tests. So, when I talk about mainstream tests correlating with symptom presentation, I'm talking about, a 60-year-old gentleman who was, who got an acute COVID infection, ended up on a ventilator, spent 2 months on a ventilator. Now, when he's trying to climb a flight of stairs, he experiences a shortness of breath. His oxygen saturation is no good. When you look at his lungs on a scan, you can see very clear pulmonary fibrosis. This is an individual who can benefit from traditional rehab approaches. This is an individual where if you put him into a pulmonary rehabilitation program and give him inhalers and give him supplemental oxygen, he's most likely to actually respond well to that and recover on a course that we can predict, that we know is going to work for someone with pulmonary scarring secondary to a pneumonia. On the other hand, we have people with a more syndromic presentation. They've got a lot of different symptoms that don't correlate to mainstream test results. So we hear this all the time. All the tests came back normal, but I still feel incredibly ill and debilitated. That is because our tests aren't testing for the right things, which more on that later. But the reason it's important to separate these groups out, and as Dr. Crane mentioned, a more common presentation for this group in the blue, the syndromic group, is going to be a 40-year-old female patient with no prior history of of issues with, comorbidities, and having a mild COVID infection did not require hospitalization, and then started to develop fatigue, post-exertional malaise, shortness of breath, exertional intolerance. The reason that it's important to separate these two groups out is because this type of patient, their experience is going to be worsened by interventional approaches such as graded exercise therapy, pulmonary rehabilitation, cardiac rehabilitation. They're not going to respond to this at all. So if we try to treat everyone with long COVID as one diagnosis, we're in for a very messy time. This is also why I would urge everybody to avoid taking any wisdom whatsoever from EHR studies. EHR studies do not differentiate these subtypes of long COVID. And so all of the correlations and associations that they produce are going to be spurious and aren't really good, studies to be trusted. EHR studies for a poorly characterized illness like long COVID are really only good for hypothesis generation. And unfortunately, because we're often mesmerized by big N's, this study used like 1.2 million people, we miss out on the nuance, and people love to write press releases about them, and it's a big mess. Point in fact, there are a lot of long COVID red herrings, which are really not long COVID at all. They're just a long tail recovery from the virus. The most relevant example to this, I think, was the Israeli study that did an EHR measure of long COVID in folks in Israel, 1.2 million people, and they showed that most people, their symptoms resolve within 1 year. I don't know if anyone saw that study, but it hit it big on the media because it was kind of like, a good hopeful study about long COVID that most people will recover. When you actually dig into the methods of that paper, they diagnosed people with long COVID if they were still symptomatic at 4 weeks post SARS-CoV-2 infection. Now, when we ran our precision recovery program, which was a remote patient monitoring program for acute COVID in March of 2020, and we were monitoring the symptoms of almost 4,000 acute COVID cases, the median length of time that people took to recover from their symptoms was 6 weeks. Now, only 20% of people in our cohort actually went on to develop long COVID, but the majority of people were taking at least 6 weeks to recover. So what that tells me is that almost everyone in our cohort would have been diagnosed with long COVID by these guidelines, and by 6 weeks, 8 weeks, 10 weeks, they would have been totally fine. Yep, they would have fully recovered by 12 months. But that's why we need to be careful about our diagnosis. That's why I love the World Health Organization guidelines, which talk about 3 months before you think about long COVID. CDC talks about 4 weeks, but I think it's important to note that the CDC has come out and stated that 4 weeks is the point where they suggest physicians start thinking about a diagnosis of long COVID, not necessarily diagnosing. They have amended their guidelines to say that 3 months is more appropriate for a diagnosis of long COVID. And then, I think we also just need to understand that people can be diagnosed with long COVID because their existing complex chronic illness gets worse after a COVID infection. And so understanding how complex chronic illness interacts with long COVID and then needs its own nuanced and specialized approach is also very, very important, because we don't want to be treating everything as though it's all the same condition, when in fact what we're experiencing is a whole universe of syndromes and worsening of conditions that is being caused by long COVID. And not to sort of throw a hand grenade into the room, but I also want to mention vaccine injury as well. I think it's really important that we acknowledge that this is now consensus science, that vaccine injury is occurring, and that people are getting very long COVID-like symptoms. There are a number of really great papers that have recently been published showing pathophysiology that is very similar to long COVID and myalgic encephalomyelitis in folks with vaccine injury. And so this is yet one more thing that we need to be prepared for as we move forward. So in terms of treating long COVID, I'm sad to say that right now we don't have treatments. We have symptom management techniques and strategies. And I'm going to quickly, burn through this because we could go on forever about how to treat long COVID. But, really conceptually is where I want to live when we're talking about treatment for right now. The first is we need to understand that approaches to treating complex illnesses are different. You can't just try one treatment in isolation. Often people have many issues going on. And if you just treat one of those issues, they're not going to feel any better. So if you try to treat one issue and they're not feeling better and you stop treating that issue and you treat the other issue, it's not going to go well. This is one of my favorite analogies, which is a ship with multiple anchors. If you pull up one anchor, the ship still isn't going to go anywhere. You need to pull up all three for it to be able to move. So combination treatments and combination approaches to what's going on is really, really important. In terms of symptom management, there are very well publicized and well published in peer-reviewed journals known triggers of increasing symptom burden. Starting to work with simple strategies to treat these known symptom triggers and symptom burden triggers is a really effective way to reduce the overall symptom burden of long COVID. We've had really good experiences using breathwork protocols. Now, we're not talking about mindfulness breathwork to calm people down and reduce stress. We're talking about parasympathetic breathing because 80% of people with long COVID have dysautonomia. We also found that the majority of folks with long COVID, and this was published in 2021, have decreased levels of carbon dioxide in their system. We don't know why, but it's measurable and it's there. And so breathwork protocols that increase systemic carbon dioxide have been shown to significantly reduce symptom burden in patients, and it's a point of care intervention that patients can use to curb and take the edge off a symptom flare as it's happening. It's a very simple basic principles breathwork policy, the parasympathetic program. It basically involves a slow inhale, a breath hold, a slow exhale. And we've been working with groups like there's a company called Stasis that we've been working with that provides a free or very low cost breathwork exercises to patients. And there's many groups out there that are now getting onto the parasympathetic breathing workflow. We also engage in autonomic rehabilitation. This is initially not aerobic exercise. This is initially very gentle, basic exercises that retrain the autonomic nervous system to not become overextended during basic functional movements. This is an example of a very initial starting point for autonomic rehabilitation, laying flat on your back, performing very slow movements that are paired with abdominal bracing and breath work so that your blood pressure and heart rate don't increase significantly as you're performing a gentle knee bend. We then slowly progress to new positions and more exertional activities in time. What we've been able to show from a case series of over 100 people at this point who have engaged in autonomic rehabilitation is that it eases symptom burden. So we see a doubling in activity tolerance, we see a halving in fatigue. But one of the things I really want to point out is that at 3-month follow-up, patients are still symptomatic. So what this tells us is autonomic rehabilitation can significantly improve symptom burden, but it's not curing anything. We're just easing the burden of the symptoms. We're still not treating the underlying cause of the dysautonomia or the underlying cause of the cellular dysfunction. And what I can say is that we've also now started to gather enough data to see that if at 3 months you're not recovering, you're probably not going to respond to autonomic rehabilitation. So we're starting to learn that there are ways that we can actually start to programatize what we're doing and what we're trying with folks with long COVID. I want to shout out to Long COVID Physio and the American Association of Physical Medicine and Rehabilitation, because on their websites, they have very comprehensive guidelines for both patients and clinicians on how to treat long COVID. And like I said, we've got a short amount of time, and they can go much more in depth than I can for right now. The final few things I want to say, we are in desperate need of biomarkers for long COVID. We all know this, but remember, you don't need a biomarker to diagnose long COVID, but I will say they're coming. So I think it is really worthwhile for people in workers' comp, people in Social Security Administration to hear, and insurers to hear, these biomarkers are on their way. We have a paper in review right now showing that with 96% accuracy, we can classify from blood biomarkers who has long COVID and who does not have long COVID. This is in its third round of review in Nature. We have a whole bunch of treatment targets based on basic physiology of patients. There is a group that has already achieved a CE mark for a machine learning based diagnostic for long COVID in Europe, where they can identify folks with long COVID with 92% accuracy. So this new generation of biomarkers is coming. So really my earnest advice to people who are blocking disability claims based on, well, we don't have a biomarker and I'm not going to accept the clinical diagnosis, you're going to be in trouble soon. I can't say it clearly enough. This is going to be a problem for you, and it's happening. And we've ignored a lot of post-viral illness in the past because there was no biomarker. This is too big for people to ignore. There are too many people who all got sick at once who are demanding a biomarker, and they're going to get it. So it's on its way. At this point, I think I'm confident to say that the science is settled. And so we really need to start believing people when they say they have long COVID, because if not, the biomarker will back them up, and then we'll be in a whole lot of trouble because we denied claims in direct opposition to CDC's diagnostic guidelines, I will add. So I wanted to finish with the voice of a patient, because I think that that's super important. I think that this is a voice that really explains a very common scenario of how people are being treated in terms of their workers' compensation, and how much emotional burden and how much work they need to do to prove that they're sick, as opposed to just being able to get the benefits that they are entitled to. And then we can finish. And I'm sorry, I've gone a couple minutes over.
So I'm recording this in response to Kate's email about disability benefits. So I was receiving disability, and then all of a sudden, one Friday in October, I just didn't get my paycheck. And I was about 5 months into short-term disability at that point. And I called following Monday, the disability center, and said, hey, I didn't get my paycheck. What happened? And they said, oh, we did a medical review, and we decided you're not eligible for coverage anymore. And I sort of lost my mind. I'm like, what are you talking about? And they said, we'll send you a full letter. And so when I read this letter, this is the part why I'm sending the video, is that it was heartbreaking, because the email said, the letter said, we can't find any medical proof that you're actually sick. And every scan you have, and every, I had a pulmonary function test at that point, like when I first got sick. I had CAT scans, I had MRIs, whatever, blood tests. Everything was coming back negative. And because of that, they said they wouldn't cover me anymore. And there was two visceral reactions to that. The first was, oh my God, like, how am I going to pay my mortgage? There was this scared, horrible feeling of, I'm not getting paid, and I'm going to have to go back to work, and I'm too sick to go back to work, and I don't know what I'm going to do. And then there was this second visceral reaction of complete depression and hopeless and so sad and upset, because you feel like nobody believes you. And, you do all these tests and nothing comes back, but you know how you feel. You know you feel like crap. You know you're not yourself. You know you're sick, but you can't point to something on an X-ray or an MRI that says, look right there, that says I'm sick. And it was so beyond frustrating that I had to see these words that said, hey, we don't believe you. We think you're making it up, and therefore we're not covering you anymore. So it was beyond frustrating and heartbreaking and demoralizing and all those things combined. I will say that now, fast forward 2 months, I wrote a 4-page letter that sort of went back and forth between emotion about how much I loved my job and how much I didn't want to be on disability, to some factual things that I found from the CDC website and from the Disabilities Act website about COVID, long COVID, and how sometimes there are no physical pieces to it. And I sort of copy and pasted their letter comments with the CDC arguments about what long COVID is and how sometimes there isn't a medical thing that you can point to, but still people still have it. And ultimately, in early January, they approved my appeal, and I am now covered with disability. But it was a very, very stressful and emotional 2 months going through the appeals process. So, if you want to know more about my story, I'm happy to talk about it.
So I think that's probably the most powerful thing I can finish on. But obviously, I need to acknowledge the fact that not everyone is in an informed position like this. Not everybody can fight this hard. And many people are, in fact, too sick to fight as hard as this individual did. And so that's what we're for. That's what we're here to do. So, thanks for listening. Just burn through these.
Are you going to translate it into English from the Australian?
Yeah. Hopefully there was an interpreter.
Thank you very much, Dr. Petrino. Our next speaker is Zoe Lascaris. She's a research assistant professor in occupational epidemiology at the Barry Commoner Center at Queens College. She draws on 15 years of combined professional and academic research experience in global and national public health research addressing exposure and health outcomes among a range of worker populations, including WTC responders, day laborers, auto workers, lead-acid battery smelters, and electronic waste recovery workers. Her ongoing research addresses the occupational burden of the COVID-19 pandemic and the emerging occupational hazards associated with climate change. She received her PhD in epidemiology at the University of Michigan and her MPH in environmental and occupational health at the CUNY School of Public Health and Health Policy. Zoe, thanks so much.
All right, thank you so much, Charlene, and thank you all for being here. As Charlene said, my name is Zoe Lascaris, and I'm here from the Barry Commoner Center. Yeah, thank you for being here. I wish I could see your smiling faces, but I know you're out there. So I'm just going to give a very brief overview of what I'll talk about for the next 20 to 25 minutes. So given that the topic of this forum is long COVID and workers' comp, I'm going to start by discussing a little bit about what we know about long COVID in the workplace. And then I'm going to take a step back and talk a little about the occupational burden of COVID-19, the little that we do know. And then I'm going to present some findings from an analysis that I did in collaboration with Dr. Stephen Markowitz, the director of the Barry Commoner Center, in a forthcoming publication that we can send out the article link in a little bit at some point. But what we did was we took a look at COVID-19 claims that were filed in New York State during the first 2 years of the pandemic. And I do want to point out that we're not parsing out long COVID claims in that analysis. At the same time, if you don't already know, and we'll probably say it a few times in this presentation, is that if you need to seek lost time coverage or benefits due to ongoing long COVID symptoms, you must have an established COVID-19 claim. So it's important that we take a look at those people that did file during the first 2 years of the pandemic, for which we have complete workers' comp data on. The third year of the pandemic we'll take a look at that soon as we are nearing the point where we'll be able to get a better picture of it. And then I'm going to go into a little bit of the policy implications, and I'll pass it off then at that point to Robert Gray. All right, so let's jump in. The emerging long COVID crisis is impacting employment. I think I could say, based on the comments from Dr. Crane and Dr. Petrino, we could say the emerged long COVID crisis is impacting employment. Long COVID, I'm sure many of you saw this headline from the Brookings Institute that primarily relied on data from the U.S. Household Pulse Survey. Long COVID is keeping as many as 4 million people out of work, and that was across the U.S. But unemployment is not the only outcome that we're seeing, adverse employment outcome. There are reports of reduction in hours and reduction in pay due to long COVID. A high report of poor work performance, and then also limited access to accommodations. And that, is not for all occupations, but definitely for those that are not teleworkable. So the same population that also had a higher risk of SARS-CoV-2 exposure in the workplace. So before we get to this disastrous outcome of unemployment, disastrous for the worker, disastrous for their family, the employer, the economy at large, we have to ask, can workers' comp help? And the answer is yes, it can. Not only can it help, it was designed to do so. It is the chief institutional mechanism for workers to recoup wage loss and access medical care for occupational conditions. Not only does the Workers' Comp Board make it clear that they cover COVID-19 with this catchy phrase, we know that workers' compensation is with you for the long haul. They are also here if you have ongoing medical issues due to work-related COVID-19. We have this kind of look into what long COVID looks like, a very little look into what long COVID looks like in the workers' claim database. The New York State Insurance Fund recently published a study shining a light on long COVID, in which they looked at the long COVID claims that they had among their accepted claims. And I am going to give you their definition of long COVID. Dr. Petrino made it very clear that that is an important thing to think about. So what they did was they used a definition of lost time from work of 60 plus days. So not the 3 months that Dr. Petrino talked about, but 60, or a treatment duration of 60 plus days. So using that definition, what they found was that 31% of awarded COVID-19 claims were for long COVID. Perhaps more striking was that 5% of awarded COVID-19 claimants were unable to return to work for over a year. So first, I want to thank the New York State Insurance Fund for leveraging their data to share some insight onto a topic that we know very little about. And I also want to take a moment to remind us that the findings derived from awarded claims data are not representative of the general worker population. We know that there are many barriers to filing a claim, and then more to having a claim be awarded. In other words, the criteria for being in this population is really, of awarded claims, is quite stringent. So what we're seeing in these data is the tip of the iceberg. They tell us very little about the magnitude of the problem in the context of long COVID. So what might we expect in the absence of these barriers? To get at that, we have to think about what is the occupational burden of COVID-19 in New York State. So workers' comp covers injuries and illnesses due to a work-related exposure, right? So 3.5 million, you're probably all thinking like, sorry, we've moved long past that. I think Dr. Crane said we're up to about 7 million COVID-19 infections in New York State. But again, I'm focusing just on the first 2 years of the pandemic. So prior to December 31st, 2021, there were 3.5 million confirmed COVID-19 infections. So how many of those were among working age populations? 2.7 million. There were also 93,867 hospitalizations among working age adults in New York State, and 6,321 deaths among working age adults. So to take this a step further, what proportion of infections were caused by a work-related SARS-CoV-2 exposure? Unfortunately, lab reporting does not include industry and occupation fields like they do race, ethnicity, or age, although race, ethnicity, as we know, is also often lacking, but age and sex. So in the absence of a unified occupational surveillance system for COVID-19 infections and deaths, we have to rely on research based in outbreak investigations and hospital and epi studies using hospital and death certificate data. To estimate that proportion of infections caused by a workplace exposure. And if we take a look at those estimates, we get a range of about 10 to 30% are what we would call occupational COVID-19. So with that number, we would expect anywhere from 272,000 to 816,000 claims. So how many were actually filed in New York State? Of those 2.7 million infections among working age adults, this is a spoiler alert. This is a key finding of the results that I'm going to present from our paper. But actual number of claims filed was 31,673 claims. That amounts to 1% of that 2.7 million. So 1% is low. I imagine other people may be more explicit in how they describe that level of utilization. But I will just say that 1% is very low. So what can we learn about that 1% in New York State? So using the publicly available claims data provided by the New York State Workers' Comp Board, we analyzed COVID-19 claims and their characteristics. So my colleague and I, we asked two primary questions. The first was who filed COVID-19 workers' comp claims in New York? And are they receiving the benefits for which they are eligible? And we answered these questions by looking at differences across several characteristics: year of filing or year of exposure or illness, age, sex, insurance type, whether or not they had a representation from an attorney or other, their industry, and their essential worker status. So before I get into the findings, I just want to point out that there were about 481,000 total claims in those 2 years, 2020 and 2021, and 6.6% of them were for COVID-19. And then I'm going to talk in more detail about close to 30%. This, what I'll call the analytic sample, 29,815 claims. We excluded claims that were canceled and those that we did not have industry information for. So again, here's this finding that this number of claims is only 1% of total COVID-19 infections among working age adults in New York State. So claims were derived primarily from 2020 injuries, workers between 35 and 54 years, and they were equally divided between women and men. We saw that about 87% were essential workers, 20% had an attorney or other form of representation, and 53% of the claims were submitted to private insurance carriers, followed by public, New York State Insurance Fund, and self-insured private. Claim and claimant characteristics differed between 2020 and 2021. In 2021, claimants were younger, more likely to be male, fewer claims with representation, and there was an increase in claims from non-healthcare sector workers. There was also a decrease from the healthcare sector. So let's look now at differences in COVID claims by industry. So I'm just going to present on the top 4 industries by number of claims, since they comprise about 87% of the total claims. We see healthcare and social assistance leading the pack here with nearly 12,000 claims, followed by public administration, transportation and warehousing, and retail trade. But if we look at the rates, which are more comparable, since we're going to divide the number of claims by the total number of employees within each of these sectors, the data tell a very different story. Here, so this is the cumulative 2020-2021 rate per 10,000 workers. We see surprisingly that the rate for the healthcare sector was surprisingly lower than public administration. So 71 claims per 10,000 workers in healthcare compared to 145 in public administration, and 117 in transportation and warehousing. So I can say, I won't get into the details here, but those leading the public administration filing were executive, legislative, and general government employees, then followed by justice, public order, and safety. In transportation and warehousing is primarily messengers and couriers. And so what is driving this result? Why don't these results align with our understanding of the hierarchy of SARS-CoV-2 exposure risk? Maybe, this is just speculation, public administration employees, executive, legislative, and general government employees are filing at a higher rate because they're also having more success with their claims. They're being awarded at a higher rate, causing something like a snowball effect. Word is getting out. And maybe the opposite is true for healthcare workers who at the end of a busy day feel like it isn't even worth applying. Maybe it's union presence. There seems to be a convergence of factors leading to differences in reporting and filing that we have to learn from to ensure a more equitable system. Okay, now we're going to talk a little bit about award status. Before I begin, I want to remind you that 87% of the claimants worked in an essential industry. So with that piece of information, you may find it surprising that only 25% of the claims received an award. 72% of awarded claims were for wage loss, so that's a huge majority, followed by medical only, and then a much smaller number for death benefits. 2%, which amounts to about 104 of the 6,321 recorded COVID-19 deaths among working age adults in New York State, resulted in a claim with death benefits. I should mention that these are claims on which a decision was made. So we excluded claims that appeared to still be in process. So this is from about 87% of them. Claimants that had an attorney or other form of representation were 5 times as likely to receive compensation than those without any representation. And claims submitted to self-insured public entities were 3 times as likely to be awarded than claims to private insurers. So who the insurer was and whether the claimant had legal assistance were key determinants of success in workers' comp claims. If we take a look at award status, we see differences across industry. Public administration, I alluded to this earlier, has the highest proportion of awarded claims, about 43%, followed by healthcare and social assistance, and then much lower proportions of awarded claims among transportation and warehousing, and only 3% among retail. Okay, I'm going to now do like a little special focus on nursing home staff, a deep dive into nursing home staff. Why? Because they are one of the only worker groups that we actually have data on for the number of we have recorded infections and COVID-19 fatalities among this worker group. So the Center for Medicare and Medicaid Services required weekly reporting of staff infections and fatalities within all long-term care facilities certified to provide their services. And the first reporting deadline was in May of 2020. So while this data may be it may be an underestimate, particularly since people reported on the infections retrospectively in May, and we know in those March and April were really hard times. But given the information that we have, we calculated that there were 46,505 infections during the first 2 years of the pandemic in New York State among nursing home staff. So how many claims did we get from the nursing care facilities industry group? 629. So if you do some simple math and divide the top number by the bottom number, we see that 1.4% of nursing home staff infections resulted in a claim. We can do the same exercise with COVID-19 fatalities. 111 COVID-19 fatalities were recorded among nursing home staff in New York State, and there were 8 claims with death benefits within the corresponding nursing care facilities industry group. So again, this amounts to about 7.2% of nursing home staff COVID-19 deaths received death benefits. So to find such poor utilization among a highly visible workforce that was over time afforded additional protections raises the concern that less visible worker populations that also experience a substantial occupational SARS-CoV-2 burden may be even less likely to receive compensation. So I will begin to wrap up here with like a general statement to conclude our findings was that the New York State workers' comp system provided modest wage and medical support to a likely sizable workforce exposed to or infected by COVID-19 on the job. A key takeaway is that COVID-19 claims account for only 1% of the total number of recorded COVID-19 infections among working age adults in New York State. So I've now said that 3 times in this presentation, so maybe you will remember it. Other systems, so I guess the question is, what can explain this underutilization, right, of the workers' comp system, particularly among high-risk worker groups? So one possibility are other systems absorbing claims and their costs. A limited number of the potential wage replacement claims in New York State may have been absorbed by emergency COVID-19 quarantine leave legislation, for example. But actually, I have a feeling that many of you in the audience today may know other types of internal policies that employers established to address COVID-19 quarantine leave early on for their workers. And that, while that was convenient and great at the time, it does raise some concerns when we think about long COVID, particularly for those that did not establish initial claims. If they are currently experiencing long COVID symptoms, who can they turn to, right? If they can't reopen that claim to address their problems. So there are a lot of remaining questions on this topic, and I would love to hear from you in the audience if you have some insight here. And I think the other group of people that we really need to learn from are the workers and gather their experience. The other question is there a need for different forms of outreach? The New York State Workers' Comp Board reported in their 2021 report that they reached about 9,600 people with their COVID-19 monthly webinars. So while that may be great and work for a certain type of worker or employer, it clearly does not work for everybody. I believe I looked at the Bureau of Labor Statistics website. I think in New York State, please correct me if I'm wrong, there's about 9 million, the civilian labor force is about 9 million people. So an obvious policy recommendation here is to generate meaningful outreach to workers to address barriers in applying and accessing workers' comp benefits. Another key takeaway is that regardless of an essential worker designation, only 1/4 of claims were awarded benefits of any kind. Compensation among nursing home staff, a highly visible and at-risk workforce, was particularly low. So again, are there artificial barriers contributing to the low rate of acceptance? Are claims dying in the system? And I'm going to leave that question really for Robert Gray to address. He's far more qualified to do so than I am. It's one of the questions that we have. Another question is compensability the issue? I am going to read to you, bear with me, one sentence, the first sentence under the heading, what information is needed to show that a COVID-19 claim is work-related? This is from the COVID Workers' Comp Q&A. Most workers will never be able to point to the moment or method of exposure to COVID-19. But workers can demonstrate the significantly elevated risk in their workplace by demonstrating the nature and the extent of their work in an environment where exposure to COVID-19 was prevalent. Okay. Does that say to you, we got your back? Does that say, we know that you went to work under extremely stressful circumstances when you may not have had access to PPE, when you thought that everything you touched probably was infected with the virus, that you then went home, you got sick, you went home, you probably exposed your children or your elderly parents, and now we're going to rely on the system that we have designed to meet this very need and right that wrong? It doesn't say that to me. It's kind of intimidating. I wouldn't necessarily know how to file that claim, and I probably wouldn't do it. So what's the alternative? To adopt a COVID-19 presumption standard in New York State to improve access to workers' compensation and encourage eligible workers to apply. So what that means, a rebuttable presumption, means that it is presumed that a worker's infection was caused by a work-related exposure. So while the employer can refute this, the onus is on them and not the worker. So this is a map with some states that adopted presumption standards for COVID-19. And I'm just going to end with like a little data on what we learned from them. So California, that has a presumption for a broad range of worker groups, the proportion of accepted COVID claims was 30 percentage points higher than in New York State during 2020 and 2021. In Washington, which has an infectious disease presumption during states of emergency, we found that 90% of COVID claims were accepted. And in Wisconsin, that had a presumption for first responders, COVID-19 claims denials for lost time doubled from 18 to 44% after their presumption expired. So, can these findings on poor utilization and obvious barriers in the system that have made headlines for over 50 years now encourage those of you in a position of power to reevaluate the principles and methods of this program to better meet the needs of workers who were injured or became ill while performing their jobs? Not only are there precedents on how to do it, it is the right thing to do. Thank you.
Excellent. Thank you so much, Zoe. Our final presenter, and I know there's a lot of questions coming in from the audience, and we're going to get to the Q&A after. Our final presenter is Robert Gray. He's the managing partner of Gray & Gray, which represents injured workers throughout the metropolitan area in workers' compensation, personal injury, and social security disability matters. Robert has practiced in the field for over 30 years, and his writing and research has appeared in a number of publications, including the New York Times, the Daily News, the Post, and the New York Law Journal, and 3 different law reviews, and a 4th upcoming article this spring. Robert was the chair of the New York Workers' Compensation Alliance for nearly a decade and continues to serve as the director of the Injured Workers Bar Association, the treasurer of NYCOSH, the labor outreach chair of the advisory board for the Mount Sinai Silikoff Centers for Occupational Health. Robert is a frequent lecturer on workers' compensation issues for a variety of organizations, including the New York State Bar Association. He's the graduate of Johns Hopkins University and the St. John's University School of Law. Robert, thank you.
Thanks, Charlene. So here's my takeaway from Zoe's talk, which I would hope would be the takeaway of everyone who's listening, and that we can make it the takeaway of people who aren't here today. We have in the state of New York, give or take 200,000, 500,000 workers who got COVID at work. And if we listen to Dr. Crane and Dr. Petrino, a significant percentage of those workers are suffering from long COVID, which is making them symptomatic and disabling them for a year, year and a half or longer. And out of that, give or take a couple 100,000, 500,000 workers who got sick at work during the pandemic, less than 10% of them have filed a claim for workers' compensation benefits, and maybe 10% of those actually got benefits. So we have, if we're lucky, 1% of the workers who got COVID while working during the pandemic getting benefits out of the New York State workers' compensation system. That's outrageous. That is an absolutely outrageous number, which shows you clearly the degree to which the New York workers' compensation system has failed to meet the purpose for which it was created over 100 years ago. So being mad is good. Having some analysis about how we got here might be useful. And then what I'm going to close with will hopefully kick off a discussion on what are the possible solutions here. One of the questions that Zoe's presentation presents is, well, are there barriers to filing? Another one is compensability the issue? A third one is, do we have a benefits issue? And then we also have to consider what are the consequences of the 99% of workers who haven't gotten benefits, or the 90% of them who haven't filed, of not filing. So I would break the barriers to claim filing generally into three categories. There are systemic barriers, which are sort of New York State labor management culture issues. There are inadvertent barriers, which were created by well-intentioned programs, but that disincentivize people from landing where they were supposed to be. And then we have a whole set of barriers that were created by the agency, by the New York State Workers' Comp Board, which is responsible for administering this law, not specifically with regard to COVID, but they have impacted COVID claims very significantly. So what are the sort of systemic barriers? Well, workers don't know that workers' comp exists. When I started in this field 35 years ago, every worker who was injured, if the New York State Workers' Compensation Board found out about it, the agency reached out to them, brought them in for a hearing, explained to them what the rights and benefits were, and found out what the claim was about. So that was a massive state outreach program for injured workers that created widespread visibility that there is a workers' compensation system and what it's supposed to do and what benefits people are supposed to get. None of that exists anymore. And the result of that is that many workers do not think of the workers' compensation system as a resource for them. And many of them are unaware that it even exists. Even for the ones that are aware that it exists, they think of it as being there, well, if I lifted a box and hurt my back, or if I tripped and fell and broke my arm. It does not register with them that workers' compensation is an available remedy for an illness. And this, again, is not an issue that's limited to COVID. This has been going on for decades in the area of occupational disease. Occupational diseases, in general, are much less frequently filed than injury claims, and this has been magnified in the COVID environment. Another specific issue for the COVID environment is workers assuming that they can't meet the burden of proof. How am I going to prove that I got COVID at work? That they do not understand the legal standard. It's not their job to understand the legal standard, but it disincentivizes them from filing claims because they don't see how the system could provide benefits for them. Another set of disincentives or a barrier to claim filing that I mentioned are other benefit systems. New York State took a number of measures in response to the COVID pandemic, which were well-intentioned. There was a sick pay requirement. There were other benefits that were provided. The result of those, the impact was, though, that a worker who missed some time from work and was paid and had their medical bills paid by their private insurance has little motivation to file a workers' compensation claim. And as Zoe mentioned, and I'm going to talk about a little bit further, this can have disastrous consequences for the worker down the road. Lastly, we have what I consider agency-created barriers. As I mentioned, the Workers' Compensation Board is responsible for administering this law. It has set up the claim process. It has set up the administrative process for benefit delivery, and many of the aspects of that process are very harmful to workers in terms of enabling them to gain entry into the system and to access the benefits that the system provides. The forms that workers are required to fill out are complicated. The claim process at this point is highly technical and highly regulated. There is little clear guidance to workers. It is true that the agency promulgates some of its forms in multiple languages, but all of the decision notices and all of the formal agency correspondence that are issued to workers are in English, and they are written in language that requires a high degree of literacy, and this shuts out significant populations of workers who have language or literacy issues. Many claims are closed administratively without affording the worker a hearing. And again, this disproportionately impacts workers who have language or literacy issues because they do not have an opportunity to talk to a person and receive information in a method and a manner that works for them. And finally, on the back end, Zoe pointed out the low rate of success for workers who do not have representation. And the only answer to that is that the administration of the law is not worker friendly, that a worker is required to get an attorney if they want to obtain benefits from the system, which is not how this was designed at the outset at the creation of this law over 100 years ago. So let's talk about some of the details. There's a claim filing process, which on its face is simple. The worker has to notify the employer that they got hurt, they have to file a claim, and they have to see a doctor and get medical evidence. How does this break down in the real world? Well, first, the worker has to recognize that COVID is an accident that they can file a claim for. I mean, you can imagine the reaction of most workers. I'm supposed to fill out an incident report for COVID, the same as if I lifted a box and hurt my back. Worker goes to the supervisor to fill out the incident report. The supervisor is going to say, you didn't get hurt at work. What's the accident date? How am I supposed to fill this paperwork out? The result of all of this is that many workers don't give notice to the employer, which theoretically can bar their claim because there's a 30-day time limitation for this. Claim filing. In addition to notifying the employer, the law puts the burden on the worker to file the claim for themselves. Seems simple. They have to file a claim with the New York State Workers' Comp Board. There's a process for this. What's the process? Well, the Workers' Comp Board helpfully provides 2 pages of written instructions on how to do this. And then it provides a 2-page form with 40 some odd fields that the worker has to complete. And then there are 2 more pages of fine print instructions. And then wait, there's another form that you only use in certain circumstances, but you probably have to use this form in every COVID case because it asks about previous medical treatment. As a practical matter, the folks who are attending this Zoom are probably capable of making their way through this process. You can probably follow the 2 pages of instruction, file the form. The board helpfully makes it available online, which does not work for substantial parts of the worker population. You might be able to make your way through the 2 pages of fine print instruction and understand that you're supposed to fill out this extra form and then get the whole thing filed. While that might work for you or me or the folks at the Workers' Compensation Board, it does not work for folks who work at nursing homes. And you saw the impact in the data that Zoe presented. It does not work for retail workers or delivery workers or hundreds of thousands of workers. The system is simply too complicated for workers to access the form, know what to do with it, and get it filed. But assuming and what happens if they don't? Well, there's a 2-year time limitation. So if the worker does not make their way through this process and file the claim within 2 years of their COVID infection, then their claim is time barred. And no matter what happens to them after that, and no matter how bad they are, and no matter what consequences they develop from long COVID or from the initial COVID infection, they are barred from receiving any benefits. So at this point, any worker who contracted COVID between March of 2020 and February of 2021 who did not file a claim for workers' compensation is out of luck. They're time barred. Their 2 years has expired. Now, if they were unfortunate enough to be reinfected a second time after February of 2021, which would be within 2 years of now, then they may be able to file a claim for the second infection. And then we'll have the inevitable arguments with the insurance companies about, well, what's responsible for their long-term problems? Is it the time-barred earlier infection, or is it the timely second infection? But assuming that they can get through figuring out that they have to give notice to the employer and getting the supervisor to take the incident report and accessing the claim form and filing it with the Workers' Compensation Board, there's a third thing they need to do, which is get a medical report from a doctor. Seems easy, right? Well, what doctors accept workers' compensation? If you need an orthopedist or a physical medicine and rehab doctor or a chiropractor or a physical therapist, you're in luck. There are many, many doctors in those specialties that take workers' compensation. If you need a neurologist or a psychologist or a social worker, it's going to be a little more difficult, but you can probably find a provider who's authorized by the Workers' Comp Board and will see you. But if you need a cardiologist or a pulmonary specialist or a vascular doctor, an ENT or a psychiatrist, good luck to you finding a doctor in the New York State Workers' Compensation System who will see you. At one point, Dr. Crane had his staff call every cardiologist in New York City who was listed as being coded by the Workers' Compensation Board. And I believe the outcome was there was one who was willing to see a workers' compensation payment. One.
Except she moved to California.
And she moved to California, he reminds me. There were 5 pulmonary specialists in the city of New York who were willing to take a workers' compensation case. So if you go to the Workers' Comp Board website, you'll find lists with many names on them. The reality is that these specialists, who of course are the specialists you need for acute COVID cases in many circumstances and for long COVID cases in many circumstances, do not exist. So this leaves the worker with a choice, right? You can file a workers' compensation claim and maybe access the benefits in the system, but you're not going to be able to find a doctor to treat you. Or you can not file your workers' compensation claim and you can get health care paid for by someone else. So those are some of the barriers to claim filing that I see. Another question Zoe asked is compensability the issue? On this one, I have a different answer. The answer is compensability is not a huge issue for those workers who were able to fight their way through the thicket of barriers that stands in their way. Almost all workers in New York State are covered by workers' compensation. There are exceptions, and one of the significant exceptions in the COVID pandemic circumstance are gig workers, Uber Eats, DoorDash. These folks have generally been deemed to be independent contractors by the Workers' Comp Board. They were obviously in high demand during the pandemic. Many of them got sick. None of them are covered by workers' compensation because they are not recognized as employees. So that's a significant carve out of the population that we really should be covering and need to cover, for whom compensability is an issue. But beyond that, the compensability standard that the Workers' Comp Board has adopted is generally fine. The board will cover COVID as either an accident. The legal test is that it has to arise out of it in the course of employment. It can include illness, or as an occupational disease for workers whose occupations routinely expose them to infectious illness. On the accident front, the board will generally accept COVID as a work-related illness if the worker can show one of 3 things. Either that they had a specific exposure to a coworker or a patron or a customer, and they became symptomatic in appropriate period of time thereafter, or if they're in a public-facing job where the nature of their job puts them in contact with large numbers of members of the general public during the pandemic, or if they're in what the board refers to as a COVID prevalent environment. You work in a hospital and there are COVID cases in the hospital. You're in a workplace where there was an outbreak in the workplace. Any of these things will qualify a worker for benefits as a matter of the legal standard. For healthcare workers, I happen to think that the more appropriate measure is that it's an occupational disease. Healthcare workers It's part of their job to be dealing with people with infectious illness or communicable disease, and the law recognizes coverage for that as an occupational disease. So the standard that the board is using for workers who make their way through the claim filing process is fairly liberal and fairly worker protective. The problem is, as Zoe pointed out, that 90% of the workers who should be filing aren't filing, and 90% of those aren't making their way through the process to get benefits. Are the benefits the issue? Well, the benefits are okay. The benefits are as okay for a worker with COVID as they are for any other injured worker. The law provides benefits for temporary disability, for permanent partial disability, although these days that's something of a misnomer. We really have sort of temporary disability and longer temporary disability because there are time limitations on permanent partial disability, which makes it non-permanent. There are benefits for permanent total disability and death and medical coverage. Temporary disability benefits, if you're out of work more than a week, you're entitled to compensation for the time out of work. Again, for workers who had COVID and received COVID pay or COVID sick pay and had relatively short periods of time out of work, they got paid by other systems, and this likely, I think, plays a role in their non or low filing rates for workers' compensation. Permanent partial disability, if a worker is unable to go back to doing what they were doing before, but they can do something, generally the way the system is structured now, they can be paid for anywhere from 6.5 to 12.5 years. And then their lost wage benefits end, regardless of whether they're able to work or not. Workers who are permanently totally disabled, which in the workers' compensation system is defined as not being able to do any work of any kind, even on a part-time basis, those workers can be paid for life. Is the benefit rate a problem? No, not really. The benefit rate is 2/3 of the worker's wage up to the maximum rate for their date of accident, which now is a little over $1,100 a week. That does leave some high-wage workers with not full wage reimbursement, but for most workers, I would think it's an adequate benefit rate. Medical treatment, if you can find a doctor who takes workers' compensation and is willing to treat a COVID case, medical treatment is covered for life. So this is an important and valuable benefit that workers can't get anywhere else. They have no out-of-pocket expenses. Their treatment is regulated by the Workers' Compensation Board, which has medical treatment guidelines and a drug formulary that sort of rigidly prescribe what treatment workers can get. Consequential injuries. In the workers' compensation system, if a worker has an original injury and then they have a secondary medical problem as a result of the original injury, that secondary problem is covered as part of the original claim. So in the COVID context, long COVID is not an independent claim from COVID. As Zoe mentioned, you have to have filed your COVID claim in order for long COVID to be covered, because the constellation of medical problems that we would define as long COVID is, in legal terms, a consequence of the original infection and will only be covered if the original claim was filed. Similarly, workers who contract COVID and then die some period of time later, and COVID was a contributing factor to the death, their survivors are entitled to file claims for death benefits. Skip over that. What happens when a worker doesn't file? Number one, the worker doesn't get any benefits. They become self-payers for their wage loss. They become self-payers for their medical treatment. They lose future coverage that they may need and may be very significant. Where do those costs go? They get transferred. They get transferred to other benefit programs, whether it's union health insurance, private insurance, social safety net programs, or more frequently to the injured worker and their families. What are we going to see as the long COVID crisis continues? We're going to see an increase in all of these costs, and we're going to see a dramatic shift in all of those costs to the plans that I just mentioned, and I know that many unions are concerned and are already seeing the impact on their health benefits from the non-filing of workers' comp claims, which are now being transferred to their benefit funds. What do we do? How can we reach workers more effectively and deliver the benefits that the system is supposed to provide for them? The starting point is we have to improve visibility of the workers' comp system. Zoe had mentioned a presumption standard. The presumption standard probably would not significantly affect the outcome of claims for workers who actually make their way through the process. The standard that the Workers' Comp Board is using is probably only about an inch shy of the degree of protection that a presumption standard would provide. However, what a presumption standard would do is demonstrate to workers that the door is open. It would be an affirmative message to workers, yes, there's coverage here, and yes, you should file, as opposed to hiding the door down the alley, where if the worker makes their way down the alley and finds the door, if they get through the door, then they get access. Outreach. Zoe mentioned the Workers' Comp Board has a series of webinars, which is laudable. The series of webinars has reached just shy of 10,000 people, which is laudable. It is unfortunate that we've reached 10,000 people out of a worker population of maybe 750,000 that's affected. And we are never going to reach the other 740,000 or so by webinar. That's just not an effective means of communication for large portions of the worker population. We could have employer-based outreach to workers in at-risk injuries. We could mandate employers in nursing homes or hospitals or other high-risk populations to distribute notices to their workers about the existence of the workers' compensation system and their right to file a claim. We could run public service announcements. Many years ago, NYCOSH ran public service announcements with some state funding for outreach to World Trade Center workers, World Trade Center responders. We could contact workers who applied for other benefits. I mean, there is data, there is information out there about workers who received COVID pay or other COVID benefit programs or benefits from other COVID programs. Those workers could be contacted and asked if they filed a workers' compensation claim and advised how to do so. We don't do any of those things. We've done nothing to make the workers' compensation system more visible and more accessible to workers. When they get into the system, how are we going to make sure that they get benefits? Because remember, 90% of the workers who are getting into the system aren't getting any benefits out of it anyway. Well, we could make the claim filing process simpler. We could give workers an initial hearing, give them at least one fair hearing in their case so that they have an opportunity to see a judge and tell the judge what their claim is about and hear from the judge about what their rights are and what they need to do to go forward, as opposed to getting a piece of paper in the mail from the State of New York Workers' Compensation Board in 8 or 10-point font that tells them in complicated language, we didn't get a medical report that's adequate for us to proceed, so we're closing your case without giving you a hearing. We could provide better access to medical specialists. That is an enormous need in the long COVID context, and frankly, it's an enormous need in the workers' compensation system in general. If we can't get doctors who are willing to get themselves authorized by the Workers' Compensation Board, the Workers' Comp Board could meet them halfway. It could approve treatment for COVID or long COVID by doctors who aren't authorized by the Workers' Comp Board and reimburse them at generally accepted reimbursement rates in the medical system. Another way we could go about it is we could devote more funding to the New York State Occupational Health Clinic Network so that the clinics in the clinic network could employ specialists to treat workers' compensation board. The clinic network was created in large part to deal with occupational disease claims. We should enable it to do what it was created to do. So those are some of my solutions, and I'm going to end there because I know that the other panelists have other ideas and other solutions, and that there are questions from the audience as well. Thank you.
Excellent. Thank you so much. On the AV side, is this working, this mic? People can hear me? Okay. So I want to first thank all of our panelists. I personally, as like a policy person, have been inspired by everything that you all shared and thinking of how we can improve the system for the better. But I wanted to first share a comment from one of our guests from the audience who said, my supervisor in an education institution talking to school nurses stated, you could have gotten it anywhere, not at work, and discouraged us from filing. Does anyone have, particularly I'm thinking of you, Robert, is that legal?
It's probably legal, and it's not by any means unusual. I mean, an employer is required to take an accident report if the employee provides it to them. But if the employer can figure out a way to discourage the employee from providing the accident report, as long as they couch their discouragement in the right way, the employer can probably get away with it.
Okay.
And I don't think that question is unusual. I think that is a widespread. I think that's a widespread representation of what's actually going on and what actually went on throughout the pandemic. Is there are lots of workers who went to supervisors and said, I want to file a workers' comp claim. And the supervisor said, well, how are you going to prove you got that at work? I don't see that that's an accident. And, it's commonplace.
Okay. So we talked a lot about a presumption standard. And one question that came up is if people who filed previously and were denied would be able to file again. Is that an issue with the presumption standard, or is that kind of a different issue?
Sometimes when the legislature adds a new right to the law, they create a window for people who previously lost their claims to refile. That's occurred many times for World Trade Center responders. So if the legislature created a presumption standard and really wanted to make sure that folks who got sick in the first year of the pandemic were covered, then along with the presumption standard, it would have to provide a reopener so that those folks would have time to file a claim under the new standard. But that would be a decision for the legislature to make.
Well, speaking of the legislature, we do have a couple of policymakers in the audience. I'm wondering, what do you all think policymakers need to understand about long COVID and the workers' compensation system in New York State? Assume you're talking to them because you are.
Go for it.
It's not fair, Charlene. I'm feeling all the questions.
There's a bunch of medical questions, so they won't be left out.
Okay. I mean, I think I outlined what policymakers need to know about the workers' compensation system, which is we have with regard to COVID, we have an enormous underfiling problem. Those underfiled claims have costs. Those costs are going to land somewhere. They're going to land on unions. They're going to land on workers. They're going to land on private health insurers. They're going to land on the state of New York, and from there land on taxpayers. The basic principle of workers' compensation is we made a decision that the cost of workplace injuries and illnesses should be borne by employers, and employers can mutualize those costs by the price of their goods and services. If we do not make sure that the workers' compensation system does what it was designed to do, then at some point, there's no purpose to having the system anymore, and we should let workers go back to suing employers. That would probably not be popular with employers. So I think the better path is to restore the system to where it was supposed to be, which is a worker-friendly system that provides easy access to benefits, that communicates to people what to do, how to do it, what they're supposed to be getting out of it, and then delivers those benefits. That's what this system is for, and it's failing miserably.
I'd just like to jump in and say that it's not simply a policy issue. I think everyone who saw that clip of that person, her tone, the way she looked, the despair she was feeling, it's a human question, right? That could be anybody's sister, anybody's mother. That could be, a friend of all of us. And so many people have this. I think one of the things that really has to be stirred in, this is an enormous problem. I mean, World Trade Center, right, at its maximum, probably impacted 500,000 people, 400,000 in the neighborhood and about 100,000 rescue workers. This is millions of people, millions being affected. How is that lady, if she has children, going to take care of her kids or of her aging parents or whatever else she has to do in her life? And that person literally could be any of us. So it's policy, but it's humanity. And we need to be thinking like humans.
Can I add one more thing?
Oh, sure.
Yeah, I think too, we all have to recognize, I'm not the first person to say this, but one, the pandemic is not over. There may be another very similar pandemic that happens in your lifetime, very likely. And so we can't, the problem is, we can't just bury it. We recognize that, this was, unique circumstances, and maybe we didn't get it right the first time, but we still can. And so not only do we need to think about, policy for the next pandemic and emerging occupational issues, but for the ongoing one, by not addressing for all these workers who are just pushing through because they can't get time off of work and they can't get treatment, there very well may be other injuries that occur because they are working while pushing through their long COVID symptoms. So these costs and these problems are just going to keep coming up. So I think that's another thing to think about when we're thinking about policy. It's not like the worst is over.
I'll feel left out if I don't do one as well. But I want to build off of that, because if policy makers are listening, I think that we've had some really compelling talks about how hard it is to get benefits. And the one thing I want to point out is that we have a cardinal symptom of long COVID is post-exertional malaise or post-exertional symptom exacerbation, meaning that the more you exert someone, the worse their symptoms get. I would ask policymakers to consider the fact that, yes, we're hot on the heels of a biomarker. We're going to have a biomarker soon. So we'll be able to prove who has long COVID and who doesn't using physiology. And so then we're also going to be starting to talk about the fact of how much harm was done by making the process so hard that you actually hurt patients worse because of, a kind of slimy attempt to discourage people from accessing their benefits. That's the next thing that we're going to tackle. We're going to start talking about how much harm was done by the process that's currently in place, and was it foreseeable that that would have caused extra harm to patients? Answer: yes. It's the first thing that every long COVID publication mentions is post-exertional malaise is the cardinal symptom of long COVID. So we should be smarter about that.
Dr. Petrino, there's a couple of other doctors in the audience who had a question specifically about the biomarkers that you discussed in your presentation. One of those doctors said many of the biomarkers shown in your presentation are associated with other viral infections. Can you explain?
Yes. So, as stated in the presentation, long COVID is not one thing. It's many things. And so the approach that people have been taking to biomarker discovery has been, in fact, to use machine learning approaches to diagnose long COVID. This is a very novel area, but this is why I brought up the fact that there is now a machine learning approach that has a CE mark in Europe and is going for FDA approval, because right now we can't tell you one unifying biomarker for all of long COVID, although the work that's coming out of South Africa showing hypercoagulability and platelet hyperactivation is in fact starting to be positive in 96, 97% of people with syndromic long COVID. Although we can't give you one unifying biomarker, we can use these machine learning approaches to say, given all the ways that we know that long COVID affects the immune system, there is an X% chance that you have long COVID based on this analysis. So I think that we are moving fast toward different subtypes of long COVID and different specific biomarkers associated with each of those subtypes. But in the meantime, we should be aware that government agencies in Europe and now in the US are considering using machine learning approaches for diagnosis.
Thank you so much. And I have a couple of, Zoe, I have a couple of questions related to your point about how there could be other pandemics and this pandemic is not over. Should we take issue with masking and other protections being rolled back in the healthcare sector?
Me too.
I think that masking and recommendations is, that's a constantly like a moving target that we're constantly reevaluating. And I think better adherence to masking is definitely needed in the healthcare sector and in other sectors. I think I really feel for individuals that work in jobs with public interface because they really can't control what the person who shows up at the supermarket, whether they're wearing a mask or not. So yes, I do think that we need to constantly reevaluate and ensure that we are protecting our workers, and actually campaign for it rather than saying like thank you essential workers. We should say encourage people to wear masks to protect other workers, and have that really kind of be the main message that gets put out.
I'd love to have a crack at this one as well. We've mentioned World Trade Center a few times today. The current death rate from COVID in the United States is basically we have one World Trade Center every 5 days. Can we just, and we have no way to treat long COVID, can we just agree as a society that we can stop wearing masks when we're not still in the top 10 leading causes of death in the United States being COVID as an entirely preventable form of death? And we have just some inkling on how to treat long COVID, which is affecting right now 1 in 10 people who get infected with acute COVID. That's 2 very reasonable benchmarks for when we can start easing back protections that stop us from, being at risk of death or a completely life-changing, debilitating chronic illness. That would be my vote.
And one question related to that, Dr. Petrino, what kind of federal and state resources are being dedicated to explore infection control research? Is there enough money going towards this?
No, NIH Recover is closing up. There's not a whole lot of more resources being put from the federal government standpoint into exploring or researching long COVID further. We're not really, the CDC is publishing papers that show us how dangerous COVID is and how prevalent long COVID is, and then in the same breath relaxing COVID protection protocols. The one that is most notable in my mind was the same day the CDC released a study showing that with every recurrent COVID infection you have, your risk of death goes up 5%. Now, acknowledged a very small number, 5% of a very small number is still a very small number, but your risk of death goes up 5% every time you have a recurrent COVID infection. On the same day, they released the mask mandate on airplanes. I can't understand how an agency, a federal government agency, can release scientific information that should scare us about an ongoing pandemic, but then in the same day make a policy decision that is completely conflicted with that scientific evidence.
Yeah, if I could just kind of, I think what's happening is we are kind of reverting back to normalcy. Everyone wants to be normal again, but remember that normal, as far as worker protection is, worker protection, occupational medicine, grossly underfunded in the United States. Remember how we had to hustle to get the mask, right? So we are not paying attention at the start of this. Got more attention during the middle of it. Now we're going back to not paying attention again, not just to this, but to other worker health hazards. And we really got to stay on it.
Thank you. And one thing that we've talked a lot about, and people in the audience may not be aware, that we have some of the same people in this room who advocated for the World Trade Center Health Program, who advocated for funding to go towards responders and survivors of 9/11. That many people are still dying as a result of occupational exposure. And one question from actually a member of the press, could there be a COVID essential worker registry similar to what we had for 9/11 and what we have? Robert, do you want to take that one?
Yeah, thanks, Charlene. I mean, that is the most frustrating thing for me about the COVID pandemic is that after 9/11, I had many workers call me, and we got them compensated in 2002, 2003, 2004. And then you got to the end of 2004, and the Workers' Comp Board ruled that claims that were getting filed in 2004, 2005 were time barred, which was, in my view, a correct interpretation of the law by the Workers' Comp Board. It was just that it was an interpretation that you could see was going to leave tens of thousands of workers out in the cold. Right. And, you know, I participated in drafting the legislation that reopened the claim filing window for the World Trade Center claims. So having had that experience with the COVID pandemic, you could see in March of 2020 and April of 2020 and all the months after that what was coming. And yet we still can't get people to create access for people to file the claims. And my concern with the COVID pandemic in relation to 9/11 is I have been concerned about the legislature's willingness to create a window for claim filing for workers with COVID as compared to what it did for 9/11 responders. And there are far more essential workers with COVID than there were 9/11 responders. So the scale of the problem is much bigger. And yet I'm more concerned about our willingness as a society and a government to do what needs to be done. So could the state create a registry? Sure, the state could create a registry. The question is, what's the state going to do with that registry?
Right.
Are we going to take the steps then that we need to take to actually give people benefits if they're on the registry? Or are we just going to say, we have a registry and your name's on it, but it doesn't do you any good? I mean, it's really about getting people the wage replacement benefits and the medical treatment that they need. So it would be a wonderful thing to do, but there then has to be action.
So we'll go to Zoe and then Dr. Petrino and Dr. Crane for any closing comments related to that or anything else you want to highlight before we end our panel at 12.
Yeah, I guess, you know, just the idea of a registry really, you know, makes me think about all the incredible amount that we have learned from the World Trade Center registry in terms of research because of the data that was collected. A COVID-19 registry, I mean, one of the biggest, for me, you know, downfalls is that we don't have any occupational surveillance. We don't ask people their industry and occupation like we do their marital status. And having that information early on in the pandemic could have really helped identify workplaces that were key sources of transmission. So I would just put a push for improving our data collection around industry and occupation, because we know what a determinant it is of people's health.
Yeah, I mean, my final point would be to policymakers. I think we need policymakers to stand up and actually make sure that a lot of the feel-good policy that is going into place is being enforced, and being enforced in a way that is actionable to folks with long COVID. You know, we saw it get signed into the ADA as a recognized disability, and yet we haven't seen people with long COVID receive work accommodations or workers' compensation benefits. They are being illegally denied this. This is history repeating. This is why we had the 504 sit-in, back in the day with Judy Heumann and the rest, to make sure that people with disabilities were able to access their accommodations. We know that if you just make the policy but don't put any language in there to enforce the policy, then it's not worth making the policy in the first place. So we need our policymakers to stand up and make sure that there is language in there that enforces these policies and make sure that people do the right thing.
Mine is simpler. These folks are heroes. Let's take care of them as heroes. Let's take care of them.
Excellent. Well, I want to thank all of our panelists. Again, to my left, we have Dr. Crane, we have Dr. David Petrino, we have Dr. Zoe Lascaris, and we have Robert Gray. Thank you again to our panelists. Thank you to everyone who's here today. And this will not be the last you hear of us. I promise we will continue to have events like this and outreach and education and advocacy to improve the lives for workers. So thank you so much and have a great rest of your day.